Hello, everybody. It's a real pleasure to be here to be able to tell you a little bit about the changes in the classification and grading of meningiomas. So just a brief outline, I'm going to talk a little bit about imaging characteristics of meningiomas, because as a pathologist, this is very important. This is our first encounter with the lesion, and it plays a role in how we approach the diagnosis as well as the grading of meningiomas. Histologic characteristics, and lately molecular characteristics, which play a more important role in the grading of meningiomas under the new WHO classification system. So meningiomas typically are homogeneous contrast-enhancing lesions with a smooth convex interface with the brain, and you can see that here and here as well. They frequently have a dural tail, as shown here on the imaging. And this would be the classic appearance of a grade 1 meningioma. Grade 2 meningiomas, on the other hand, frequently have a lobulated architecture on imaging. And when we see a lesion like this on imaging, we immediately suspect a higher grade meningioma, a grade 2 lesion or a grade 3 lesion. And that's important as a pathologist when you're going to intraoperative consultation, for example, have this information about the imaging characteristics of the lesion. Similarly, grade 3 meningiomas tend to be larger lesions with very complex architecture. Common anatomic locations of meningiomas include the optic sheath, right, or factory groove, clinoid, sella, clivus, in the convexity, parasagittal location, intraventricular meningiomas originating from the choroid plexus. So intraventricular tumors can be meningiomas, and that's an important consideration. Falx or tentorium, the cerebellopontine angle, right, in the posterior fossa, the common location for meningiomas, and also in the foramen magnum. One quick note about cerebellopontine angle lesions, and it's that frequently schwannomas in the differential diagnosis of these lesions, but the dural tail versus these, what we call the ice cream cone sign of schwannomas, helps us, before we even take a look at the tissue or the histologic characteristics of the lesion, in differentiating a meningioma with a dural tail from a schwannoma. So in terms of histology, there are 13 histologic subtypes of meningiomas that are recognized by the WHO, and this hasn't changed in the new classification system. Many of these subtypes are a WHO grade 1 designation, unless they have specific characteristics that warrant a higher grade. We have some histologic subtypes that are associated with a grade 2, which are clear cell and chordoid meningiomas. And historically, papillary meningiomas or rhabdoid meningiomas were assigned a WHO grade 3. However, that has changed under the new classification system, and I'll tell you a little bit more about that throughout the presentation. So these lesions are not automatically a grade 3. They should be graded just as we grade the majority of meningiomas. And these are the features that are taken into consideration when we assign grade to meningiomas. One is the histology, like I just mentioned, chordoid type or clear cell type, mitotic count, 4 or more mitosis per 10 high power fields, warrants a designation of WHO grade 2 meningioma. The presence of brain invasion is also associated with a WHO grade 2. Or 3 out of these 5 histologic features, which include necrosis, nucleoli, shearing architecture, small cell change, or high cellularity. A meningioma has 3 out of these 5 histologic features. It warrants a designation of WHO grade 2. Now, WHO grade 3 meningiomas, historically, papillary and rhabdoid type, this is no longer the case. But if a meningioma has anaplastic features or resembles a sarcoma or a carcinoma, those features do warrant a higher grade designation, so WHO grade 3, and elevated mitotic activity of 20 or more mitosis per 10 high power fields. And under the new classification system, there are certain molecular alterations that warrant a higher grade, in particular mutations in the promoter of the telomerase reverse transcriptase gene, TERT-P, CDKN2AB homozygous loss, or loss of BAP1. So this is an example of a psammomatous meningioma. This would be numerous psammoma bodies with meningioma cells interspersed, and this would be a WHO grade 1 meningioma. Here is another pattern of meningiomas, the microcystic meningiomas. And I'm showing these patterns because they're harder to associate with meningiomas because they the histologic features do not resemble the classic whorls and psammoma bodies that we tend to associate with meningiomas. Numerous cysts, right, in this lesion. This would be a microcystic meningioma, also WHO grade 1. Secretory meningiomas have these eosinophilic globules, which we call pseudopsammoma bodies. And these meningiomas tend to have significant edema, and they're frequently associated with this combination of KLF4 and TRAF7 mutations. The pseudopsammoma bodies can be highlighted with immunohistochemical staining for EMA or CEA. Chordoid meningiomas have these cords of cells in a mucin-rich matrix. They resemble chordomas. Clear cell meningiomas have these epithelioid cells with clear cytoplasm. The rhabdoid meningiomas have eccentric nuclei. They're no longer automatically a WHO grade 3. And the papillary meningiomas, which have this papillary architecture with perivascular pseudorosettes, similar to what we see in ependymomas, for example, they're also no longer automatically a WHO grade 3. There is some overlap between the histologic and the genetic alterations of rhabdoid and papillary meningiomas, in the sense that you can have papillary architecture with rhabdoid cytology. A little bit about clear cell meningiomas. Most common locations are lumbar cistern, and they can occur without dural attachment, as well as the cerebellopontine angle, with or without dural attachment. Clear cell meningiomas can have extensive collagen, so a lesion in the lumbar cistern with these large blocks of collagen should raise the consideration for the diagnosis of meningioma. They may have these petaloid tyrosine-rich crystals. So there can be some unusual histologic features in these meningiomas in the lumbar cistern, which in combination with some unusual imaging features, or at least features that we do not typically associate with meningiomas, may present a diagnostic challenge, right? There's no dural tail to suggest a dural attachment. So when we look at a differential diagnosis of a lesion like this in the lumbar cistern, we should consider a schwannoma, myxopapillary ependymoma, which are classic lesions at this location, but also meningioma, in particular the clear cell sclerosing subtype. Now, let's go into a little bit more detail and talk about WHO grade 2 and grade 3 meningiomas. So WHO grade 2 lesions, as I mentioned before, clear cell histology or chordoid histology, brain invasion, 4 or more mitosis pertaining high power fields, or 3 out of 5 histologic features, which are seen here. Here's an example of brain invasion. We have nests of meningioma cells that are surrounded by brain parenchyma. So this would be a WHO grade 2 meningioma. Scalp and bone invasion are not criteria for a WHO grade 2 lesion. Brain invasion is. You can see how this meningioma has invasion of the scalp, but there's a smooth convex architecture here, like it's a smooth interface with the brain. So this would most likely be a WHO grade 1 meningioma. However, this meningioma has what we call the mushroom sign with these lobules, this lobulated interface with the brain, which most likely will be a WHO grade 2 lesion. However, invasion of the scalp or the skull does not play a role in grading. Sheeting architecture, this is what we refer to, just sheets of cells, no particular complex architectural pattern. Micronecrosis, as you can see here, or small cell formation. We see these clusters of small cells. Sometimes they can be confused with lymphocytes, but they're actually meningioma cells that have small amounts of cytoplasm. Now, the meningioma WHO grade 3, we no longer use the word anaplastic in the diagnosis. We just refer to meningioma WHO grade 3 or meningioma WHO grade 2. The grade 3 meningiomas will have 20 or more mitosis pertaining high power fields or anaplastic features. Here's an example of a WHO grade 3 meningioma. This one has a fibrous pattern. It has increased mitotic activity. Frequently, we use the PHH3 antibody to highlight mitosis. As you can see here, 3 mitosis in this field, and it has an increased proliferation index of 24%. And this will be significantly higher than the proliferation index that you see in grade 1 meningiomas, which tends to be less than 5%. It's a meningioma with rhabdoid features. You can see the eccentric nuclei in these meningioma cells. And this particular example had a BAP1 mutation identified by next generation sequencing, as you can see here, that correlates with loss of expression of BAP1 by immunohistochemistry. And this meningioma will be a WHO grade 3, not because of the rhabdoid cytology, but because of the loss of BAP1. And this mutation is associated with higher rate of recurrence. and E1 as a designation of WHO grade 3. So loss of BAP1 expression is something that under the new classification system is associated with grade 3 in meningiomas. This is a BAP1 mutation identified in this case. It's a nonsense mutation at amino acid number 392. So last, a little bit about the molecular changes that are incorporated into the classification of meningiomas. We've learned a great deal about the molecular alterations in meningiomas. Loss of chromosome 22 is very frequent, and it's seen in the majority of meningiomas, and each of these bars represents one patient. Mutations in NF2 are frequently associated with loss of the chromosome 22. So NF2 is in the chromosome 22, so that's why there's a lot of overlap between these two. TRAF7 and KLF4 frequently co-occur, and these are associated with secretory histologic subtype. Mutations in AKT and SMO. And there is an association between the location of the meningioma, in particular when we look at the skull base, and the molecular alterations. NF2 meningiomas, typically in the posterior fossa. Meningiomas that have AKT or TRAF7 mutation tend to be in the midline. Similarly, meningiomas with SMO mutations. So just to review, SMARC-E1 mutations are strongly associated with clear cell morphology. So clear cell meningiomas, almost all of them will have SMARC-E1 mutations, and those are WHO grade 2 lesions. Papillary and rhabdoid meningiomas will frequently have BAP1 mutations. And the BAP1, loss of BAP1 expression is associated with a WHO grade 3. It's the BAP1 alteration, not the papillary or the rhabdoid histology, what's associated with a WHO grade 3. TER promoter mutations are associated with the WHO grade 3. So the presence of a TER promoter mutation in the meningioma, one is a higher grade. Similarly, CDKN2AB homozygous loss. And there are other alterations that might be associated with shorter time to recurrence, but they're not considered as part of the grading criteria under the current classification system. So just an example, here we have meningiomas with TER promoter mutations. In red, we see meningiomas that do not have TER promoter mutations. They have much longer progression-free survival than meningiomas that have TER promoter mutations. So there's a striking difference in the probability of recurrence between these two groups of meningiomas. Similarly, homozygous deletion of CDKN2AB, when there is preservation of CDKN2AB, there is improved progression-free survival in comparison to lesions that have homozygous deletion of CDKN2AB, shown here by the yellow line. I'm going to finalize by talking a little bit about the methylation classification or the methylation classes of meningioma. This is something that is not currently incorporated into the classification system, but it's an active area of research. And there is a probability that in the future, this may become part of the classification system of meningioma. So methylation profiling studies that look at the genome-wide methylation have identified 6 classes of meningiomas. 3 are benign, 2 have an intermediate behavior, 1 is malignant. So you could compare these to WHO grade 1, WHO grade 2, and WHO grade 3 if you were going to assign a WHO grade to these methylation classes. And there's a correlation between the methylation class and the mutations. And you can see here, CDKN2A, B loss, homozygous deletion is seen in the malignant class by methylation profiling. So there's that correlation. Similarly, TER promoter mutations are seen in the meningiomas with higher grade. So there's that correlation between the mutations and the methylation class, and the behavior assigned by the methylation class. In contrast, meningiomas with NF2 alterations are usually in the benign categories. This is just a summary of that. Here you see the methylation classes with intermediate or malignant behavior that have TER promoter mutations or CDKN2A-B deletion. They have worse progression-free survival than the methylation classes that are benign. These 3 methylation classes benign here have an improved progression-free survival in contrast to meningiomas that have TER or CDKN2A-B alteration. This is just a reclassification of the meningiomas based on the methylation class. And here's the histologic grade, WHO grade 1, grade 2, and grade 3. Here we have the histologic subtype of those meningiomas. Notice papillary and rhabdoid meningiomas here. By methylation profiling, they go to benign methylation classes. And in contrast, some meningiomas that were assigned WHO grade 1 would cluster by methylation with meningiomas that have more aggressive behavior. So there's some increase, there's an improvement in the classification of meningiomas by incorporating methylation analysis. And that's something that might be incorporated into the classification system down the line as methylation profiling becomes more widespread utilized. So just to summarize, meningiomas WHO grade 2, we have imaging features that are suggestive, the lobulated appearance. We have clear cell or chordoid histology, 4 mitosis per 10 high power fields, brain invasion, or 3 out of these 5 histologic features. Grade 3 meningiomas, we also have imaging features that will suggest a higher grade. Papillary and rhabdoid meningiomas are no longer automatically a grade 3. BAP1 mutations are associated with grade 3 behavior, 20 or more mitosis per 10 high power fields, and these molecular alterations of third promoter mutations, CDKN2AB homozygous loss, or loss of BAP1 expression. And we have the 6 methylation classes that can accurately predict the clinical outcome of meningiomas and might be incorporated in the future. And that is the end. Muchas gracias.